Okay, well, welcome to this evening's workshop. This is learning workshop number 3 for the COPD Collaborative. Just as we get started, I would like to acknowledge the traditional owners of the lands in which we're meeting and pay my respects to elders past, present and emerging, where our office is based in Penrith, which is Darug land. So just like to acknowledge those peoples. My name's Rebecca Paget. I'm the Program Development Officer for the Primary Care Initiatives team at the PHN, and I manage this COPD Collaborative program. This is just the agenda for this evening. So we're going to look at the data so far, comparing sort of some of those measures that we take during the course of the collaborative, so we can have a little look at that. We've got Linda Ora, who will be speaking to us about supportive care in COPD. And then at the end, we'll touch on kind of keeping the momentum going after the end of the collaborative and then the final steps. So this evening's learning objectives are, by the end of this session, you'll be able to discuss the COPD collaborative progress to date, to describe the importance of advanced care planning for patients with COPD and an understanding of available local services, to understand the importance of continuing quality improvement after the end of this first year in the COPD collaborative, and then learning about the second year of the COPD collaborative as a way to continue with the quality improvement. So let's just touch on the data. So this is from clinical audit number 2, which I sent in an email a week or so ago. And this data shows your progress over the course of the program, gives you an indication of the areas where the improvements are being made. And it also shows the average of all the practices included. So you can sort of compare how you're going overall with some of the other practices. And this is included as a way of encouragement to see the progress of everyone over the course of the program. So this first graph shows us the number of active patients with a coded diagnosis of COPD that you have within your practice. So it's helpful to know the changes that are happening in this number, especially when you compare it to some of the other graphs. You can just sort of see where some of the changes are happening, but also if there's any data cleansing that's happening, this graph can sometimes show that too. So this one shows the patients who have an indicated diagnosis of COPD. So these are patients who don't have COPD, but there are indications of. And this is a good population to focus on for your Plan, Do, Study, Act cycles. So one way to do this is to create a list of these patients, find out who they are, and then review them clinically, do the clinical assessment, spirometry if it's indicated, and then you can make an official diagnosis of COPD or not. And you can work on reducing the number of patients on this graph, this list. So for those that do have COPD, then you can make sure that they're receiving the required treatment so that they get the official COPD diagnosis and then they're getting managed as a patient with COPD rather than just an indicated patient. This graph gives an indication of your patients with COPD who have had a spirometry result during the course, recorded during the course of the program. And this spirometry can be done in your practice or elsewhere and recorded in the software. And just to mention, the regulations around spirometry testing within practice are, you can now test within practice. You just need to make sure you've got the inline bacterial viral filters. So just to point out, you can see sort of some of the progress that's happened, particularly in practice 6. You can see they've had an increase from about 71 to 81% of their patients with spirometry recorded. So you can see there's a little bit of an improvement there. And just to mention as well, see practice 2 and 3 don't have any spirometry recorded on this graph, and that could be that no spirometry has been recorded, or it could be that the results are being recorded, but they're not being recorded in the right place for the data program to pick it up. So this is another place where you could sort of start to look and see if improvement could be made. It could be just as simple as making sure that the results are being recorded in the right place for the software and then for the data program to pick them up. So this could be another focus of the PDSA as well. So this graph indicates patients with COPD who've had pneumococcal vaccination recorded. You can see in practice 2, 6, 7, you can see the improvements that have happened. As with the spirometry, this can also be recorded elsewhere and then added into your records if the vaccination was done elsewhere. This graph is tracking the completion of GPMPs for patients with COPD. So as part of this program, we encourage you to review patients with COPD and check that their GPMP is complete, or do one if it's overdue or if they haven't had one done. And this one tracks the team care arrangements recorded, and also if this is relevant for your COPD patients, we encourage you to get those completed as well for your COPD patients. This is a measure of smoking status recorded, so you can see across the board that's being really well done and really well recorded for almost all of your patients with COPD. So this can be something to look at as well. Looking to get your number up to 100% could be some place to work as well, your PDSA focus. And this final graph measures the percentage of patients with COPD who've had influenza recorded, influenza immunisation recorded. And this one's likely to increase in the next few months once the flu vaccination starts too. So when looking at PDSAs to complete, take a look back at these graphs as well as your clinical audit reports. And these give you something to focus on and work towards. At the end of this program, there's a final clinical audit, number 3. And so during some PDSA cycles, focusing on the information from these graphs, by the end of the program with that next clinical audit, you'll be able to see the improvements that have happened. So this is how the use of the data can help you track your progress through the program. So that brings us to the end of the data section. And now I'd like to introduce our guest for this evening, who's Linda Ora, a clinical nurse consultant for supportive and palliative care, who'll be speaking to us today about advanced care support for patients with COPD. So I'm going to hand over to you, Linda.
Thank you. I'm just going to share my screen. Thanks so much for the invitation to speak to the COPD Collaborative. My presentation is called Supportive Care in COPD, and supportive care, for those that don't know, is an emerging area that is part of supportive and palliative care. So it's really about introducing palliative care practices that are around symptom management, support for good quality of life, and planning ahead for end of life, whenever that is, into the care of a patient with COPD or some other non-malignant disease, or indeed cancer. And it's about the early introduction of those principles and practices. So the earlier the evidence says that the earlier that we get involved, the better the patient outcomes. So I'm just going to flick to my next screen, there we are. So I'm just going to talk a little bit about what COPD supportive care is in our district. And I'm going to talk about advanced care planning as well. And then I'll finish with talking a little bit about opioids for breathlessness. So as we know, as I'm sure you well know throughout this program, that COPD is a very symptomatic progressive disease that affects many people. It can be quite complex in terms of the disease course, where people have fluctuations of becoming unwell, having treatment, then becoming unwell again. And often these exacerbations can be quite unpredictable. So with the trajectories, you can see here that the one in the middle is that sort of general organ failure trajectory, and compared with cancer and frailty, it's definitely distinct, and often there can be a deterioration preceding the death of the patient, which, you know, can perhaps not be anticipated, particularly for family, but also for health professionals as well, given that the person has been on a trajectory like this for many years. So predicting the exacerbation that's going to be the last one can be very difficult and challenging as well for families to come to terms with, as to what occurred, what went wrong when all the other treatments seemed to work in the past. So we know that there are some barriers around advanced care planning in this patient cohort. And that is largely because of the disease trajectory, but also that healthcare professionals have concerns about raising issues around end of life and taking away patients' hope. And also that there can be a little bit of a lack of continuity of care as a patient moves between general practice into hospital through the care of other services. And so often there can be a little bit of, it can be a little bit uncertain as to who should be having the conversation with the patient. So the respiratory specialist in the hospital may not see it as their job. They may see it as the GP's task to raise those issues. And similarly, GPs might see it as a specialist's role. So the Nepean COPD service is an outpatient service that has been operating for a few years. It is only resourced to support Penrith local government area, but it provides support for patients who have been admitted to Nepean Hospital with a primary diagnosis of COPD, and it follows patients up for 4 to 6 weeks and is a nurse-led service. And the respiratory nurses focus on the person's health goals and managing their symptoms and providing support around action plans, education with inhalers and those sorts of things. They also have a physiotherapist that can provide home-based physio programs, pulmonary rehab programs, and there's also medical specialist respiratory medical outpatients that the nurses coordinate the appointments with. And this, as I say, service has been running for some time, and what we started a couple of years ago when we recognised that a supportive care approach may benefit these patients is that we added the supportive care sort of arm of the service, if you like. And so myself as a palliative care trained nurse, I work with the COPD service to provide input and mentorship and advice and support around specific palliative care approaches, as I mentioned earlier, around symptom management and support for the family, and really taking a holistic approach in addition to what the respiratory team provide. And so I integrate the ability to sort of normalise the discussions around end of life and also advanced care planning. And if and when patients are approaching end of life, I'm able to facilitate a transition to the palliative care services when required. So advanced care planning is, as we know, an opportunity for people to share their personal values and preferences around their future medical care. And it's really, important that we establish these goals and preferences to make sure that the care that the patient's receiving during their chronic illness matches their preferences. An important point around advanced care planning is not just for the patient to be expressing their preferences and values around treatments, but also for them to have a think about if they were unwell or unable to speak for themselves, who would speak for them, and would that person know what their preferences are? So advanced care planning, as you know, is an umbrella term that really talks about, encapsulates the conversation and may or may not lead to an advanced care directive being written. Advanced care directives can be written. Ideally, it is helpful for patients to write their preferences down and have it witnessed, but advanced care directives can also be verbal if their substitute decision maker is a person who would be able to speak for them, and if they're confident with that. As I say, advanced care directives can just be spoken, but it does help to write them down. A substitute decision maker, as I said, is an important part of the process, and that may not always be necessarily a person who might be considered to be next of kin. And as you're probably aware, that there is a hierarchy within the New South Wales legislation that a formally appointed substitute decision maker, such as an enduring guardian, is at the top. And if there's nobody in that category, then it's a spouse, including same-sex partners. And then if there's no one in that category, it's a carer or a friend or somebody who's involved in that person's care. And then obviously if there's no one there, then it can go to guardianship. So within the work that I do with the COPD service, doing a PhD research project around this, and one of the aspects of the research was to explore what was already known about patients with COPD and their views on advanced care planning. And essentially, in the review, we found that patients are ready and they're willing to have discussions around advanced care planning, and they're quite comfortable with considering the future. They want to have conversations with trusted relationships and health professionals, which is often their GP or their practice nurse, someone who they know and trust, and that they want to be involved, and they want their substitute decision makers to be involved in that shared decision making. So advanced care planning in COPD, I think, is a little bit different and perhaps unique compared with discussing it with somebody who has cancer, for example, who is experiencing a decline that can be somewhat anticipated and perhaps is more short term. Because patients live with COPD for a long period of time and perhaps have exacerbations or periods of time where they might be close to death and then they come back again, what's difficult for patients is to really sort of anticipate what dying might be like and what they would want in that situation. Rather, advanced care planning in COPD is about preparing patients and their substitute decision makers for the types of decisions that they might have to encounter in the future, but just an understanding that they may have to make in the moment decisions, given that exacerbations can be unanticipated and the person may become very unwell very, very quickly. So having these conversations, as we say with patients, it's really about having a conversation when you're well. And that's why we're having the conversation now. It's not because we think you're going to die anytime soon. It's about you expressing your views and your preferences so that your substitute decision maker, your caregiver, knows what you would want. And so in a crisis situation, they're not left guessing. They have a good sense of what you would want in that situation if recovery appears uncertain. So the Wish, Worry, Wonder framework is a communication framework that is evidence-based, and it's a way of broaching the topic that aligns with the patient's hopes and is, from a health professional perspective, allowing you the opportunity to be truthful and while at the same time being sensitive, and then opening up the conversation in order to make a recommendation. So a way to do this with a patient with COPD might be, firstly, to set up the conversation to get permission and to check the readiness of your patient to talk about advanced care planning. So an example is, I'd like to talk to you about what's ahead with your illness and do some thinking in advance about what's important to you so that I can make sure we provide you with the best care. Is that okay? And so you might then offer something along these lines. I wish things were better with your COPD, and I'll continue to look for options that could work for you to slow the progress of it as much as possible. However, I worry that you and your family won't be prepared if things don't go as we hope. So I wonder if it's okay if we can discuss a what-if plan today. So this is a SPICT tool, which you may or may not be familiar with, but it's a screening tool that offers, I guess, the opportunity to be able to identify patients who may have some of the general deteriorating indicators of deteriorating health, at the same time as having one or more life-limiting conditions. And so if a patient is in the category of the top section and also that middle section, then it is prudent to review their current treatment plans, maybe consider a referral for specialist palliative care, but most certainly arrange the opportunity to be able to have an advanced care planning discussion. This is an advanced care directive, which is the one that we use in New South Wales Health. It provides a Q&A section at the front and then a pro forma within it that patient, which talks about their preferences, values around CPR, where they would prefer to be if they died, organ donation, and also who their substitute decision maker is. We commonly use these in services within New South Wales Health, and so you might start to see patients potentially coming to see you in the practice with a directive that may or may not have been completed, but certainly wanting to have that discussion, or if they've already had the discussion, that they come to you with one that's already completed to be kept on record and obviously start the conversation. This is an example of a couple from patients that we've worked with over the last year or two. So this particular patient talked about the fact that they would preferably like to be at home. And when we asked them about were there any specific things that their person responsible needed to know about them when they're, about their preferences when they were dying, this person said that they wanted death to be as quick as possible. They didn't want to linger. They didn't want people, family hovering over them. They didn't want to end up in a nursing home, and they would like their family all together when they died. And then this person had spent time within a residential aged care facility as in terms of respite, but it was really important to them that they didn't die in an aged care facility, and they were very concerned that they were going to die in pain, and so they wanted to make that very, very clear. So what is particularly helpful is having a conversation with your patient about what their preferences and values are, and also facilitating that conversation with the substitute decision maker present so that they are aware of what would be important to them when the time comes, whenever that is. The other thing that's occurred in the last few months, or about a year and a half, is that we're able to upload advanced care directives onto the electronic medical record within the hospital. So an advanced care directive is a patient-held document, usually on paper. It could be that pro forma, but it could be a different one. We're now able to scan and upload it to the system. And so ideally it should inform the resuscitation form, which, as you're probably aware, needs to be revisited at every admission. There is an opportunity now with the new system for doctors in the hospital to be able to indicate that the resus form is valid for 3 months for patients who are frequently requiring hospital admission, or, for example, coming to a renal unit, that they're coming 3 times a week, that it doesn't need to obviously be discussed every time they come in. Obviously, advanced care planning in general, if your patients have questions about that, this is the Advanced Care Planning Australia website, which is full of some great information that is also specific to individual states as well. And I just wanted to finish talking a little bit about opioids for breathlessness. So there is now very strong evidence for the fact that low-dose opioids are very effective for chronic breathlessness. And we've certainly seen this in the COPD service, where the majority of patients have, moderate to very good benefit for their breathlessness when we commence low-dose opioids. So there's really, this particular paper summarizes the evidence very well, and I've just pulled out a few points, which I won't go through every point, but just to say that the opioids reduce that sensation of feeling of the urge to breathe, so that sensation of breathlessness. And it also is helpful for patients to take in anticipation of doing an activity, so whether that's showering or going out or whatever it might be, that obviously it's not going to take away the breathlessness completely, but it can certainly make it easier and can make recovery from breathlessness a little bit quicker after activity. As I mentioned, so it's moderate level 1 evidence, which is pretty reasonable, and most of the evidence that we have is for people with COPD. The other point that I wanted to make was that generally speaking, if we start a patient on immediate release morphine, which is the usually the Ordine liquid, it's usually 2.5 milligrams QID PRN, just to test how often they may need it and how they respond to it. And generally what we find is if people are going to have an effect from the morphine, it's going to be up to around 30 milligrams a day. And generally speaking, if you don't get an effect up to that dose, there's not really much evidence to support going higher, and it will just, usually cause drowsiness and other side effects, undesirable side effects. And so the data tells us that actually 70% of people do respond even with just 10 milligrams a day. A lot of people worry about respiratory depression, and the evidence shows that with small doses of regular, either controlled release morphine, which I'll talk about in a minute, or the immediate release Ordine, that clinically relevant respiratory depression is limited, very limited, and there's only sort of single case reports around any adverse effects around that. The other very important point is if you're starting patients on low dose morphine for breathlessness, to really ensure that we're providing good management and education around constipation. Nausea and vomiting, usually if they're occurring, dissipate within the first day or two. If a patient does have fluctuating renal function, then we may consider switching to a different opioid like hydromorphone or oxycodone if they're at risk of toxicity, if they've got renal impairment. Kapanol is the slow release morphine capsule, which was, I think, last year added to the PBS for chronic breathlessness. And so this is just some information here around using that for chronic breathlessness. And even though there are times where we might start a patient on some PRN Ordine of 2.5 QID PRN, similarly, we have also gone straight to a slow release preparation for some patients as well, and found that that's been beneficial. And sometimes we use a combination of the two. So it might be 10 milligrams of Kapanol and 2.5 milligrams QID. And patients then have a sense of control over having some additional morphine to use when they might go out. And also just to have a sense of they've got something if they're breathlessness, if they have sort of breakthrough breathlessness, if you like. That's all I have. Unless there are any questions, I'll throw back to you, Rebecca.
Yeah, thanks so much for that, Linda. That was very interesting and really relevant, and especially with that COPD focus. So thanks for focusing in on that. I think that's really, really helpful and really relevant. So we'll just jump back into just the final stage of this presentation. If there are any questions, feel free to use the chat box at any stage. And just as we finish off, I just want to touch on looking at sustaining quality improvement, especially as we come to the end of this collaborative period. We're entering into the final activity period of this part of the program. So thinking about what's it going to look like once this program wraps up, and how can you maintain the momentum that you've established during the program already. So let me just flick across, sorry about that. So as we enter this final activity period, thinking about how you can maintain this momentum, it's called continuous quality improvement. And this involves maintaining an innovative approach to change. So keeping that mentality of making the small bite-sized changes to try new ways to streamline processes or improve the patient accuracy of your records, that type of thing. So, but keep in mind those small changes that we look at over the course of this program. It also involves, sorry about that, here we go. It also involves consistently measuring for improvement. So this is about keeping or continuing to use the PDSA cycles that we have been using as a way of tracking and measuring the changes that you want to be making. So keep using that tool, the PDSA cycle tool, with the new things that you want to be working on within your practice. And also involves reevaluating the systems and processes that you have regularly to identify what's working and what's not. So this is where you can use that study section of your PDSA cycle to see whether the changes that you've tried will be achievable long-term. How did they impact the people that were involved? How did they impact the patient records, the patient outcomes? Is this something that you could consider implementing at a bigger scale within your practice? So keep looking at that study section of the PDSA cycle, and that can be really helpful for evaluating the quality improvement and whether it's going to be helpful long-term and bigger scale for your practice. So I guess I encourage you to consider how you can keep quality improvement as a regular part of your practice activities. And so these are just some helpful tips: monitor, highlight, share, and review. And that's really kind of similar to what we do with the PDSA cycle. So kind of keep that in your head. Consider incorporating quality improvement into any team meetings that you have, any processes that you realize are lagging or sluggish. Think about perhaps introducing a PDSA cycle to address that, or workflows or that type of thing. You can keep using the small sort of bite-sized trials and changes, and then kind of see whether you can incorporate that larger scale in the long term as well. And also can be not just COPD related. Think about other aspects, other workflows where the PDSA cycle could be helpful. So that's sort of that idea about continuing the quality improvement that you've been doing in this program and looking at expanding it out and incorporating it in the daily activities of your practice. Another thing that could help you is joining phase 2 of the COPD Collaborative. So this COPD Collaborative does run as a 2-year program. And so the program that you're completing now is phase 1, year 1 of the program. And if you want to, you can continue into the second year, which is phase 2, which will start in July this year. This has a focus on this continuing quality improvement. And it's a way to kind of work on incorporating this more long-term, but with still a little bit of support from the program as well. This part of the program has a focus on smoking cessation. So there's a workshop around that. There's 4 PDSA cycles to complete. It's a little bit lighter overall, but it's about continuing within your practice those things that you've been working on this year with a little bit of external input and support for that. There's support from the PHN ongoing as well over the course of that program. If you would like to continue with phase 2, do let me know and we can get that set up for you come July. So this brings us to the final section of tonight's workshop, and we'll just go through the next steps after this workshop and what will happen. So milestone 6 is the next step, and this is completing a couple of training workshops which are delivered online through the Lung Foundation. They're self-directed study and they take about 30 minutes each. So part of this milestone is that each clinical staff member will need to complete 2 of these online training workshops. If you scan the QR code or click on this link, it will take you to a registration form so I can grab the correct details and your contact details. I will send that through to the Lung Foundation. They'll register you for the courses and then they'll give you the login details and all of that. We do it this way because the courses are provided free for participants of the COPD Collaborative. So if you do it through this way, you don't have to pay for them and the cost is covered. So there are 3 training courses available. They're called, one of them is Inhaler Device Technique, another is Manage Exacerbations of COPD, and the final one is Who Really Has COPD. So if you go to that form, complete it, then you can choose which of the two out of the 3 training courses you'd like to complete. If you don't complete the form, 2 courses will just be assigned to you. So if you want to choose, please go ahead and fill out that form. Following milestone 6, we've got the wrap up of this final stage of phase 1, which is the end of activity period 3, and that's where the final PDSA cycles number 6 and 7 are due. That's due in April, and I will be in touch closer to that time, but I would encourage you to start working on some of those PDSA cycles now so that it's still fresh, and then come April you can sort of check the progress from this current clinical audit to the one that happens right at the end. And also phase 2 will start in July. So thank you. That does bring us to the end of this workshop. Please complete the evaluation by clicking on the QR code or following that link. These slides will be provided along with the presentation recording, so you can follow those links as well there. Any questions? And thank you for attending or watching along.